Hello guys, welcome to our channel. Today we are going to discuss the physiology part 2 and I'm going to cover the cardiovascular system, respiratory system and the renal system. Okay, these are the most important systems after completing the neuro and the nerve. For that video, please watch the part 1. And so those who are new to this channel, please do subscribe and share with your friends guys. And let's start the discussion. First, we are going to discuss about the respiratory system. So I want you guys to know about the some classification, that is a Weibel's classification, which consists of the 23 generations. Okay, so these 23 generations subdivided into the conducting airways and the exchange airways. What is mean by the conducting airways, guys? The first 16 generations, they are the dead space. Okay, and the second exchange airways, and from 17th to 23 generation, those are the airway exchange. Why we calling this dead space? Because there is no airway exchange, only air is passing here but no exchange. So here only the alveoli which is going to exchange the air, that is why these are the exchange airways. Next, the maximum airway resistance is seen in the medium sized bronchioles. Next, cells of the airway. We have the different types of the cells, and first the basal cells, which are known as the stem cells of the airway. Dust cells is nothing but alveolar macrophages. Clara cells is for the regeneration of the uh, respiratory system. Club cells, these club cells have the special structure. What is that? The non-ciliated cuboidal cells. Basically, respiratory system is ciliated columnar epithelium, pseudo-stratified columnar epithelium. But club cells are specifically, they are non-ciliated and the cuboidal cells. What is importance of the club cells? They are also progenitor cells and degrades the toxins using the cytochrome protein 450. Okay. Next, another cells, type 1 pneumocytes, type 2 pneumocytes. So from here the structure here you can see, this is the alveoli, and these blue color structure is the type 1 cells, and here you can see the type 2 is the red color structure. So let's see the different types, type 1 pneumocytes and the type 2 pneumocytes. Type 1 pneumocytes are the flat, like squamous and large area they are going to cover, and type 2 pneumocytes, they are small and cuboidal in shape, and they are producing the surfactant, which is more important. What is surfactant? Surfactant is produced by the type 2 pneumocytes, and it is starts producing in the 20 weeks of the intrauterine life and present in the amniotic fluid by the 28 weeks and fully mature in the lungs by 35 weeks. So if there is a deficiency of this surfactant, that is seen in the respiratory distress syndrome, hyaline membrane disease, and also acute respiratory distress syndrome in the adults. So what is the constituents of the surfactant? It is made of the diphosphatidylcholine lecithin, which is also known as lecithin, sphingomyelin, and surfactant protein A and D, which is important for the lung immunity, surfactant protein B and C, surfactant function. So the major is the lecithin, which is almost 80% in the surfactant. What is the main function? It will prevent the surface tension and collapse. So by that the lung compliance will be increased. Here you can see. So this is the residual volume. If there is a residual volume, no residual volume, what happens guys? This will collapse. So to prevent this collapse, surfactant is maintaining this lung compliance. And thyroid cortisol will increase the surfactant production, whereas increased insulin can decrease the surfactant production. Next, mechanics of the breathing. Whenever you are inspirating, you are actually in the active process, like external intercostal muscle, diaphragm is going to contract, and scalenate and also sternocleidomastoid muscles also going to contract. And opposite to that, expiration is a passive process, and all these muscles will be in the relaxed state. And next, forced expiration is also an active process, but here internal intercostal and the abdominal muscles is going to contract. Next, what is breathing guys? Basically the breathing is in simple diffusion, like O2 inhalation and the CO2 exhalation. It is works by the Boyle's law. What does the Boyle's law explains us? Pressure is indirectly proportional to the value. That means if there is increased pressure, there will be decreased, sorry, if there is an increased volume, there will be decreased pressure. Okay, during the inhalation. In the exhalation, decreased volume but increased pressure. So this is how Boyle's law helps the breathing of the O2 and CO2. Next, some of the pressures that you have to remember. Intrapleural pressure. I am talking about inside the pleural pressure. What is it? Whenever in your resting state, it is minus 2.4, inhalation minus 6, and exhalation minus 2.5. Whenever there is a more minus, that will attract the air inside our body. Alveolar pressure, it is resting 0, inhalation minus 1, exhalation plus 1. Okay, this is how the pressures vary in the inhalation and the exhalation. And transpulmonary pressure between these two, that is alveolar pressure minus intrapleural pressure. And next, lung compliances. What is mean by the lung compliances? Lung compliance is nothing but it is indirectly proportional to the surface tension and the elastance. So if there is a more elasticity, that means the lung compliances will be decreased. If there is an increased surface tension, so the lung compliances will be decreased. That's it. Okay. So the maximum lung compliances is seen in the expiration and minimum is seen in the inspiration. Why? Because I said that surfactant is going to maintain the lung compliances. So if there is a more surfactant, more lung compliances, right? So whenever the expiration, the volume is decreased, right? When the volume is decreased, alveoli become the small and all the surfactant will come together, that will increase the lung compliances. Whereas the minimum inspiration, the lung compliances is less because here you can see the lung volume is more, the all the surfactant is scattered, so there will be compliances will be less. So that's why the exhalation have the maximum and the inhalation will be having the minimum. And coming to here, the chest wall compliances, here you can see this question has been also asked in the examination, guys. This is the chest wall compliances, and here you can see this is the lung compliances, this is the lung and chest compliances. Okay, this question has been also asked, please do refer it. Next, coming to the oxygen hemoglobin curve. What is the oxygen hemoglobin curve? Basically, at normal, there will be sigmoid curve in our oxygen hemoglobin circulation. But if there is a some of the conditions that may shift to the right side and some of the diseases will be shift to the left side. So that means if we are shifting to the right side, that means the affinity of the hemoglobin and oxygen is decreased. If it is in the left side, it is increased affinity. So let's see some of the what are the examples of the right side shift. Increased temperature, increased 2,3 DPG, and increased acidosis. These all going to cause the right side shift. And on the left side, opposite to that, decreased temperature, decreased 2,3 DPG, and decreased acidosis, indirectly alkalosis, and also carbon monoxide. Next, coming to the ventilation. The total lung alveolar ventilation is 350 ml, guys, because the remaining 150 is the dead space. So dead space should not be covered. So total is the 350. The ventilation into the number of respiratory rate, 350 into 12, 4.2 liter per minute. And the perfusion here you can see. So the perfusion is divided into the three types like apex and the base. So in the base there will be high flow of the circulation, and in the apex there will be minimal circulation. So, so the general VQ concentration is a 0.8, which is normal, and if it is a 0, that is due to foreign body obstruction in the bronchioles, and if it is infinite, this is due to pulmonary embolism. The circulation, the perfusion is decreased here. Next is spirometry. Coming to the spirometry, here you can see the spirometry graph. This is the tidal volume, inspiratory reserve volume, and expiratory reserve volume, and coming back to the normal. And this is the left, this is the residual volume, whichever is left in the volume even after the expiration of the maximum expiration. So what is the importance of the residual volume? Again, it is going to prevent the problem from the collapsing of the lungs. So tidal volume is a normal inspiration and the expiration. IRV is the maximum inspiration. ERV is the maximum expiration. And residual volume is the leftover air after the maximum expiration. There are the capacities also in inspiratory capacity, which will cover the inspiratory reserve volume and the tidal volume, vital capacity ERV plus IRV and the tidal volume, and FRC going to cover the residual volume and the expiratory reserve volume, and total lung capacity will be combining all the volumes of the lung. Next, here you can see this is the flow meter. We are going to check, guys, the functional capacity of the lungs. So for example, after the forced expiration value of the 1 second, there will be 78% of the air will be expired. At the 2 second it is 94%. At third second it is the 97% of the functional volume capacity. Okay, so normal, you are going to see this graph. This is the expiration graph and this is the inspiration graph. Okay, if it is a restrictive disease such as a pulmonary embolism, the pattern will be decreased because the air cannot come from the fibrotic lung, right? So there will be decreased expiration at the functional capacities. Next, obstructive pathway, you are going to see the expiration is damaged more. Whereas here you can see the inspiration is much affected in the restrictive. In the obstructive, it is the expiration, the one which will be more affected. And fixed airway obstruction, both the inspiration and the expiration is problem. And extrathoracic, whereas the inspiration is affected, and intrathoracic, again the expiration is the affected one. Next, this is also last year question that has been asked. Normal expiration pathway. This is the normopnea. Expiration, inspiration, expiration, inspiration, expiration, inspiration. Next, coming to the Boytott's breathing. What is the Boytott's breathing, guys? So there will be high waves and suddenly apnea, and again high waves and suddenly apnea. So that is the Boytott's breathing, and this is seen in the neuron damage. And Kussmaul's breathing, seen in the diabetes mellitus ketoacidosis, and how it is going to all the hyperopnea that is seen in the Kussmaul's breathing. And Cheney-Stokes breathing, Cheney-Stokes breathing will be hyper, hypo and apnea, hyper, hypo and apnea. So this is seen in the Cheney-Stokes periodic breathing, seen in the hypoperfusion of the brain when there is a respiratory center damage. Next, types of the hypoxia: hypoxic hypoxia, anemic hypoxia, stagnant and histotoxic. The more common is the hypoxic. Why hypoxic, guys? This is due to decreased oxygen content seen in the COPD patients. Anemic hypoxia, decreased hemoglobin, anemia patients. Stagnant hypoxia, the flow is damaged because it is occluded by the thrombus that is seen in the MI. Histotoxic, the tissue cannot take that oxygen that is seen in the cyanide poisoning. Next, moving on to the cardiac cycle. So whenever we are discussing the cardiac cycle, first I want you guys to understand the what is the pathway of the general pathway of the cardiac cycle. So basically there will be first atrial systole. What is meant by the atrial systole? Atrial contraction. That means atria is going to push its blood into the ventricles. So after that, the blood is filled in the isovolumetric contraction, and what happens here? The all the valves is closed. Whenever I say isovolumetric, all the valves is closed. And immediately rapid ejection. What happens during the rapid ejection? The mitral and the tricuspid is closed, which will cause the S1 sound, and the atrial and also the aortic and the pulmonic will be open here. And after rapid ejection, there will be slow ejection, and again there will be protodiastole. That means a very small, very minor second of the protodiastole. That means here the aortic closure will be seen, but there is no sound here. And isovolumetric relaxation, all the valves are closed here. So rapid filling, in the rapid filling we are going to see the S2 sound. Why? Because aortic and pulmonic is completely closed, which will cause the S2 sound, and the mitral and the tricuspid will open to rapid filling into the ventricles. Then slow filling, which will cause the diastasis, okay, which is the slow filling diastasis, and again coming back to the atrial system. So this is how the pattern will be run. So the contraction, which will be the systole, and the relaxation, which will be the diastole. And how can you calculate this by the murmurs, guys? The this is the systolic, so which will cause the S1 sound. mitral and tricuspid valve is closed, which will be causing the S1 sound. So whenever you are closing, you are going to get the regurgitation, right? The mitral tricuspid regurgitation, pulmonary aortic stenosis. This will cause the systolic murmurs. So the diastolic murmurs are mostly pulmonary and also the aortic regurgitations and mitral and tricuspid stenosis. Due to S2 closure of the aortic and the pulmonary closure, you are seen in the diastolic murmurs. Next, coming to the pressure volume graph, this is also asked in the examinations, and this is pattern is seen in the this is the pressure, and here you can see the value. So the volume is increasing here, and once the volume is increased, that will cause the isovolumetric contraction and rapid ejection, slow ejection, and isovolumetric relaxation. So this is how the pattern works. So at the point C, mitral valve is closing, that means S1, and at point F, aortic valve is closing, that means here S2. S2 will be seen. So this is the pattern of the pressure value graph. Coming to the action potential, this is the atria. So here you can see in the atria. So the first here, these are the phases that you have to remember, guys. So this is the zero phase, and here you can see this is the third and this is the fourth. Okay. So I will write here for you guys. This is the third, this is the fourth, I'm sorry. So this is the fourth, this is the zero and third phase. Okay. So what happens here at the zero phase, calcium influx, and at the third phase, potassium efflux. And again here also the sodium influx and the potassium influx that is seen in the phase 4, right? Come again. So phase 0, what you are seeing, guys, in the phase 0, calcium influx, okay, and which will cause the depolarization. And phase 3, potassium efflux, there will be completely back to the repolarization. Phase 4, sodium and the calcium influx, which will be causing the action potential. Next, coming to the ventricles, here you can see the ventricles. In the ventricles, you have to understand this is the phase 0, phase 1, phase 2, 3, and the 4. Okay. In the phase 0, what happening in the phase 0? Here you can understand by the image itself. Phase 0, there will be sodium influx, right? Depolarization is seen. Next, phase 1, sudden early repolarization because potassium is going out. Next, phase 2 is a plateau phase. Why? This is a straight phase. Why? Because calcium is coming inside and potassium is going outside. That is causing the plateau phase. Phase 3, again the potassium is out, repolarization completely happened. And fourth phase is the resting membrane potential, where you are going to see the sodium out and potassium in. Next, ECG waves, important ECG waves. What is the P wave significant? Atrial depolarization. QRS is because of the ventricular depolarization. T wave is due to ventricular repolarization. So here you can see P wave, atrial depolarization. QRS, ventricular depolarization. T wave is due to ventricular repolarization. Coming to the JVP waves, here you can see JVP waves, guys. Sudden A wave is the atrial contraction, and then there will be slope, and again C wave, small C wave will be seen, that is due to tricuspid bulge, indirectly ventricular contraction. And next, X descent. X descent is due to right atrium relaxation, and Y wave is formed due to Y wave is formed due to the right atrium filling, the pressure is increased, and again Y descent is due to the emptying of the right atrium. Next, blood pressure. So whenever there is increased blood pressure, what happens? Our baroreceptors in the carotid sinus and the aortic arch will be activated. They consist of the cranial nerve 9 and cranial nerve 10. So this will activate and this will shoot up into the circulatory system, into our cerebrovascular system, and immediately the parasympathetic system will be activated and sympathetic system will be inhibited. So that will cause a decrease in BP. So BP, remember the baroreceptors means break. You are breaking the BP of the increased blood pressure. Whereas if you are the decreased blood pressure, it will activate the RAS system, the renin-angiotensin system. It will activate the aldosterone, increase the sodium levels, and increase the cardiac preload and increase the blood pressure. Some of the definitions that you should know: cardiac output is nothing but the heart rate into the stroke volume. Normal is the 5 liters. What is the stroke volume? Stroke volume is nothing but the end diastolic volume minus end systolic volume. The normal is the 70 ml. What is the end systolic volume? The volume that left at the systole, and diastolic volume, the volume is left at the diastole. What is the normal? 50 ml by the 120 ml. What is the preload? End diastolic volume, the stretch before the isovolumetric contraction. So whenever you are going to stretch the ventricle before the isovolumetric contraction, that is the preload. And afterload is the how much you are going to eject. The resistance during the ejection is the afterload. Ejection fraction is nothing but the stroke volume divided by the end diastolic volume into the 100. Chronotropy means the heart rate, inotropy, contraction, bathmotropy, action potential, dromotropy, conduction, lucitotropy, relaxation. Wind casal vessels are known as the aorta, resistant vessels are arterioles, diffusion vessels are the capillaries, capacitance vessels are the veins. The vein bridge reflex is seen in the right atrium. Whenever there is an increased venous retin, it is going to increase the atrial reflex. That means heart rate will be increased. Basal gyrus reflex is seen in the right ventricle. Whenever there is an MI or the any attacks, that will release the serotonin, so heart rate and the BP will be decreased. So these are the important two reflexes that you have to remember. Moving on to the renal system, most important renal system for the functions of the filtration, reabsorption, secretion and the excretion. But how the filtration works? There will be filtration unit in the glomerulus, which will be consisting of the basement membrane, endothelium and the podocytes. Podocytes have the special proteins like nephrin and the podosin. What is the filtration process? Just basically, if you observe from this image itself, here you can see there will be hydrostatic pressures and the oncotic pressures. From the glomerular arterioles, there will be increased hydrostatic pressure, and from the glomerulus, there will be here the Bowman's capsule. Here, this one is going to give us the oncotic pressure, which is approximate 28 to 30. And from the capsule also we are going to get the hydrostatic pressure, that is symbolic in the green. Here you can understand. So one is from the arterioles, it is giving from the space and from the capsule. So this is the filtration that is we are going to see. So glomerular hydrostatic pressure 60 mmHg, glomerular capillary 32 mmHg, Bowman's capsule hydrostatic is the 18 mmHg. So if you combine this, so this is the glomerular hydrostatic pressure minus capillary plus hydrostatic. So 60 minus 30 plus 18, approximately 10 to 12, which is the normal glomerular filtration rate. How we are going to regulate, guys? Basically in the two types we are going to regulate. One is by the constriction and other one is by the relaxation. Okay. So first, this is the efferent arterioles. Let's imagine. So this is the Bowman's capsule. This is the capillaries, and these are the efferent. Okay, these are the efferent that I am discussing now. So if the efferent arterioles are constricted, what happens? The no blood will be going here, right? So the glomerular filtration will be decreased and renal blood flow also decreased, seen with the example of the norepinephrine. Let's see if I dilated the efferent arterioles. If I dilated, that will increase the renal blood flow and also GFR will be increased, seen in the prostaglandins. If I am going to block the efferent, okay, efferent, other side I am going to block it. So what happens? The GFR will be increased. Why? Because the efferent is going to bring the blood here, right? So the GFR will be increased and renal blood flow will be decreased. Okay. Next, seen with the angiotensin. Next, relaxation of the efferent arteriole, seen with the it will increase the renal blood flow and also decrease the GFR. It is just opposite. Here you can see constriction increasing the GFR, and here it is decreasing. And relaxation, here it is increasing the renal blood flow, it is decreasing. Example is the ACE inhibitor. And GFR is a normal 125 ml by minutes. Inulin is the gold standard. Creatinine is the most common used. Cystatin C is the newly commonly brought into the market. Okay. Next, proximal tubule. The maximum action is here is the reabsorption. Because of the active transport, it is going to get the maximum reabsorption of all the particles, all the elements, and everything is reabsorbed in the proximal convoluted tubule. Because of its high surface area, even the 100% glucose is also absorbed here. Loop of Henle. Here the loop of Henle is two types. One is the descending for the maximum for the water. Ascending is for the sodium, potassium and the chloride. Distal tubule is action is for the sodium and the chloride. Collecting duct is due to two. One is the ADH hormone for the H2O like water reabsorption, and there will be epithelial sodium channels for the aldosterone and ROMK channels that is for the potassium. Next, loop of Henle also have the other mechanism that is a counter current mechanism. Counter current multiplier, I am talking about the loop of Henle. So what it is going to do guys, it is maintains the osmolarity. It will increase the osmolarity and again decrease the osmolarity. So the osmolarity is maintained by the counter current multiplier. Counter current exchanger by the vessels. Here you can see this is the vessels that will maintain the exchanger, whereas the medullary hyperosmolarity will be seen. Next, diuretics action that I want you guys to remember. Proximal convoluted tubule. There will be proximal convoluted tubule. The main action is the carbonic anhydrase inhibitors. Example, acetozolamide. And here you can see the distal convoluted tubule, thiazides, chlorthalidone, the sodium and the chloride channels will be blocked. Loop of Henle, descending loop of Henle, there will be osmotics mannitol. Thick ascending limb, there will be furosemide. Loop diuretics, sodium potassium chloride will be blocked here. And collecting duct, potassium sparing agents such as the spironolactone. And cystometrogram we discussed in the last revision video also. The cystometrogram is the PYQ of your exam. What is the cystometrogram guys? Simply we are going to calculate the volume and the pressure of the bladder. Okay, so in the first phase, here the first phase, there will be increased value. These are the important and points, this is the second one that we have to and here you can see the volume is consistently increasing and pressure is constant. Once there will be increased pressure, there is the chance that you are going to take the micturition. So this is the cystometrogram. So these are the some of the important topics that you have to revise. And for the last 1 month in the May that we are going to release the Triple book, and those who are interested, because last year also we have released the Mission 200 scores with the Triple book. So please do register after the release of the registrations guys, and those who are new to this channel, please do subscribe and share with your friends. Until then, happy preparation and see you guys.